A Dochitect's view of healthcare design. Brought to you by the Institute for Human-Centered Design.
Hi everybody, I'm very happy to be here. I came in from New York City today, flying out to Toronto later, but very happy to have a few hours today in Boston. I love Boston. I'm from Montreal, and they're very similar cities. So I will answer the kind of question I get most of all now. I did architecture first, a lot of architects in the family. And then during my master's thesis for architecture, I realized there was this whole area of healthcare design. And I started touring hospitals, I had the AIA fellowship, and I went around and came to Boston. And all the while I looked at the clinicians at the bedside and thought, I really want to be doing that. And so I went to medical school. And at the end of med school, I found myself on rounds, counting the tiles, looking at the ducts, and saying, how can I make this space better? So I really just tried to blend the two industries together. And I think the hybrid professional is something we're seeing a lot more of these days. A lot of my clinical colleagues are doctor researchers, clinician educators. You know, our world is complicated, and to solve a lot of the problems, especially in healthcare, we need diverse thinking. So I came back after my medical school. I actually went overseas to Australia. I went down to Texas, did some medical planning in architecture firms. And then I decided to go back and do my residency training. And I'll talk a little bit more about residency for those of you who might not know, but it's the period of internship after your medical school. It's quite grueling. I did it in New York at Columbia Presbyterian. And so during that time, that was 3 years that just ended a couple months ago, I kept 2 notebooks in my white coat. You know, young docs always keep a notebook for little medical tidbits throughout the day, but I had my design book. You'd be surprised how many nurses, doctors, physical therapists come up and say, let me tell you what works and what doesn't, so just jot it down. So this is kind of a mishmash of that journal, essentially, but feel free to intervene and ask questions as we go, and hopefully it'll be interesting to you and spark some discussion. So I like this slide. It's a reminder to me every week when I get my New England journals. This is in the header of the perspective page when you open the front cover. And I'd never really looked at it that carefully before, but one day I did. And you can see some scientific clinical images, anatomy, cellular level. But over here, there's a column capital. I get all excited about this, my doctor friends or whatever. But to me, it reminds me that there's a huge side to medicine that is in fact an art, a lot like architecture. It's a very right brain, left brain. And so today, I thought I would talk about design for patients a little bit, talking about windows, maybe the hazards of being in a hospital, which I wasn't aware of before I worked in one, talk about falls a little bit and integration of things like palliative medicine. But I'm really going to focus on designing for the staff, which is something I tend to advocate for very strongly. I'm going to tell you where the doctors are spending their time. You might be surprised because medicine is changing quite quickly in terms of how we practice. We'll talk about burnout. There's been a lot in the media. We'll talk about a few physical exam and medical exam conventions that I think are helpful when you're designing clinical spaces. And again, we'll talk about interdisciplinary care and some design trends going forward. So this slide is how Penny and I met. This was my first week in the ICU at Columbia, medical ICU. This is Miss T. She's in her 80s. Some of you may have heard this story. I tell it a lot. It was a big moment. And we were rounding on her, and she was probably demented when she came into the hospital, had dementia, but had become quite delirious. And she had a tracheostomy in her neck, a tube. She couldn't talk. She was very agitated. Her heart rate kept going up and up. And we couldn't figure out why. So we call that tachycardia, a fast heart rate. And on rounds, someone said, it wasn't me, someone said, I wish it was me, he said, maybe we should move her. Because she was in this room, up here, no windows. In our ICUs in New York, half of them have no windows. Why don't we move her across the way? Doctors sort of passed it by and we continued rounds. But then someone said, wait, do you have any evidence for this? And that keyword evidence, we had an entire discussion on rounds about the evidence for daylight. And we moved her that day across. Next morning on rounds, heart rate was better. Now, there's many things that could have contributed to her heart rate normalizing. But the key to the story is really the doctors and the clinical team thought about design and thought about the built environment in their care plan. And to me, that was the biggest thing that I took away from it. So I wrote an article about it. called it RX Window Bed. It came out in the Journal of the American Geriatric Society, and I teamed with Kirk Hamilton, who wrote it with me. Some of you may know Kirk, who really is one of the father figures of evidence-based design. And the reason we teamed is because that evening, when this happened, I wrote to him and told him the story, and he said, "This is great. We should talk about it, and we should get that message out there." And that's where we come to this article. Penny, I'm not stealing your thunder. Okay.
You can tell my story.
So a few weeks, months later, I'm again in the same ICU, the medical ICU, and I get a page. And it's an outside number. I thought, who's paging me? And it was Penny. And she said, I read your article. Let me tell you about my experiences as a patient with the window. And it was fascinating. And so we started communicating at that point and decided to team together and write about a view from and on the window, perspective of a staff and patient. That came out in the HERD journal, Health Environments, Research and Design. So we're talking about windows, we're talking about views. This is another ICU that I've worked in, the coronary care unit, the CCU. And Mr. R was in this bed. You can see the nice window. We've got a great window here. We're in New York, we have the Hudson River. And so I came in one morning on rounds and I said, "Mr. R, it's a great day, look at the sunrise." He was not intubated and he was talking. And he said, "Hey doc, I can't really see that. So you tell me what it looks like." We have a head wall that cuts directly in the field of vision. So kind of making the point that it's not enough for just the placement of a window. So much so that in Florida, for nursing home design, it's not enough to just have a window in a nursing home room, but you need a vista. And so there's that emphasis on having actually a sight lines and something to see. What about mortality? Do you think that design impacts whether patients do well or not do well? It's an interesting study. This is our ICU at Columbia, the same one that Miss T was in, actually. I think she was in maybe this room. And it's written by David Leaf, who was a resident before me, a few years before me. And he noticed that when he worked in this ICU, if he stood in the main station, he couldn't see these rooms very well. And he posed the question, and it's a simple question, do patients do better or worse? And it was actually came out in Chest Journal. It's a very good journal. And then HERD actually did a bit of a revamp of the original study in the last year. So he actually looked at how sick patients were. In the ICU, we have a scoring system called the Apache score to determine sort of how sick you are at baseline. And he found that if you were really sick, that you might experience higher mortality rates when you were in those rooms with low visibility. And it's kind of tucked away in this journal somewhere. It's a recent study, 2010, but that's a huge, huge finding, in my opinion. What about patients coming to the hospital and then going home? Once they're done, we often send them to hospice if that's where they need to be, and really they're near the end of life. Or we send them to rehab. We send a lot of patients to rehab. The hospital, I never realized, is a really bad place for you. And I'll tell you a little bit more in 2 minutes why it's so bad. But skilled nursing, maybe home with services. I mean, our goal is independence, but if you look at some of the studies, there was a study where they had 60 patients over the age of 75 come into the hospital. And at the end of it, 60% were not independent, which means they're either going to nursing or rehab, and then 15% had to be completely put into nursing homes. Couldn't go back into home with services or have independence, just because of the hospital stay. One of my geriatrician colleagues, I'm very interested in geriatric medicine, this Dr. Taffet down at Baylor, he's the chairman of their program. He made a nice little kind of analogy, and I sketched it in my book. So younger adults are sort of, we're on a large mountain. We've got a long way to go before we get to the edge. But as you age, that cliff really narrows, and it truly does become a cliff, where just a little bit can push you over the edge. There's just no reserve. This is a photograph of one of our ICUs. There's a patient in here. This is the equipment. I remember them saying to me, go put in a special line in his wrist. I had no idea how to get in the room. To make the point that he's not moving anywhere. He's not moving a muscle, right? If you're old, you're losing 5% muscle mass per day if you're an elderly patient in bed. If you're young, could be a young man in your 20s, 30s, 40s, 1 to 1.5%. That's a huge difference. So on the wards, our rule of thumb when we round is for every day an elderly person, and you can say elderly is 65 and over, but really we're talking about 75 and really more 85 and over. For every day they're there, it's a week of rehab. And usually they stay at least 3 to 5 days, so they're not going home after that much deconditioning. This is a great article. It's from the early 90s by Dr. Morton Creditor, but I like the graphic he used. At the top you see someone who's aging. Things happen when we age, our bones get weaker, our skin gets fragile. But put those people in a hospital, and you have delirium, they aspirate and get pneumonia, they get pressure sores, delirious, requiring restraints, all kinds of bad stuff, this horrible cascade leading to nursing home. Some of my geriatrics colleagues actually say in 20 years we won't have hospitals. Everything will be done at the home, and then we might have some acute care ICU beds. An interesting idea. But what about this? We design as architects around the patient bed. Okay, so bed is central. We build the room around it. But I sort of like to pose the question to the group, should we actually be doing that? Is the bed really the focal point? Dr. Creditor says there is no evidence that shows the therapeutic value of bed rest. That's interesting. We almost never write orders for strict bed rest. Sometimes after certain procedures, yes, a few hours here and there, but we don't want you on your back lying in a bed for days on end. But there's often nowhere else to go. Very difficult for patients to get into a chair if they even have one. So I thought because we talked about the patient room a little, I'd focus on falls. I did a big study at Columbia on patient falls. It took us 3 years. We collected falls data. And I think it's an area of interest for many. Falls is something that we don't want to happen in the hospital. Here's a typical patient room. It's something we developed when I was overseas in Australia. We looked at visibility into the room. We looked at the handle from the bed to the toilet room. But where's the evidence for falls? We know we grade evidence down here, with very good evidence that bed rails don't reduce falls. In fact, they cause worse injuries. Patients try to climb over the bed rails, get tangled in and twisted, and it's pretty awful. We know through Roger Ulrich and a few others that single rooms allow for families, and that might decrease falls. We have semi-good evidence for that. And in visibility, we have semi-good evidence again. But all of these other design elements, putting the toilet room on the same side, making larger bathrooms, putting these continuous handrails, we just don't know. These are best practice. Okay, so that's what we know. So if you read all the studies on falls, they talk about the patient room. Patient bed, patient toilet room, patients transferring. That's where falls are happening. At Columbia, we said to ourselves, this is the Presbyterian campus up in New York at 168th Street. Here's the George Washington Bridge. These are the really old Presbyterian buildings. And this is the Milstein building, which is our main inpatient building, built in the late 80s. Are falls happening anywhere else? There weren't a lot of studies that asked that question. You know, it's a big campus, as you just saw. It takes multiple city blocks, and we're moving patients all the time, and they're moving themselves. Even families are walking around. And if you ask Roger, he'll tell you wayfinding isn't really about signage. And he has this great number where he says signage is really 15% of good wayfinding. When you ask him what the other percentage is, he says it's good architecture and good planning. So the study we did looked at 1,822 falls over a calendar year in 2011. So that's a lot of falls. And the top 3 results, which I thought I'd share, this was published in the American Journal of Medical Quality a few months ago. But yes, 81% of falls are in the patient room. We knew that. But I thought it was fascinating that 20% are not there. So where are they? So they are in the inpatient units, but we saw falls happening in the emergency department, in the ICUs, in the OR, moving patients around the hospital, in the public lobby, in the clinics. Something to think about when we design. The falls are not only happening in the patient room. When patients come in and they look really frail, we usually slap on a bright yellow gown, flashy bracelet, fall risk. We put on the bed alarm, fall risk. 73% of patients who had all those things still fell. So, are we doing enough? And a 95-year-old grandmother comes in, We know she's a fall risk, but most patients in our study were under 50 who fell. About a quarter of them. One postulation for this, which we talked about in the paper, was Columbia's a tertiary care center. We have a lot of transplant patients. We have a lot of younger cancer patients who are coming in for clinical trials. So because the patients might be younger and sicker, that might explain this result. But still interesting to consider younger patients as fall risks as well. And I thought I'd touch on palliative care. Does everyone know the philosophy behind palliative care and symptom management and integrating into medical care early on? There's been some studies, and we talk about this a lot in medicine, and medicine is really shifting in that way to integrate palliative care earlier. And I just thought I'd share this graphic. It's from a New England Journal article that I sketched based on the article, but this is our traditional model where you have a diagnosis, let's say cancer, and you're treated, and as it comes to sort of the last days, you're treated for your pain and nausea and all the symptoms. They took two groups of patients and they integrated palliative care early on with one group right at the beginning and at the end traditionally with the other. You won't be surprised to know that this group was found to have a better quality of life. Makes sense. They lived longer. That was pretty surprising to a lot of the doctors. What about our resources in healthcare? This was in the Huffington Post and it caught my eye about a year or two ago. So this is the money we raise for breast cancer, for prostate cancer, for heart disease. But then compare that to the number of deaths and from what? Heart disease, COPD, chronic obstructive pulmonary disease, diabetes. A little bit of a disconnect, right? But this is only my own sketch. It's just my own thinking during residency, but I would doodle that I thought there's a bit of a disconnect in terms of where we tend to focus our design energies and where we really use the space. So to me, I feel that a lot of us are focusing heavily on the patient room, a lot of emphasis, especially when I was down in Texas, on lobbies and public spaces. I'm Canadian and I've been in Australia, so there's emphasis is different in different countries. Procedural spaces, but the staff space, the corridors, the fire stairs, that's all kind of down lower. But the interdisciplinary workspace is really where we're at all day. I'll tell you later how many minutes I'm at the bedside per day with the patient. You might be surprised. And the patient room kind of drops in my sketch here. Before we go on, since I'm sort of shifting from patients to staff, I wanted to show a video clip that I think illustrates the residency model. So I mentioned it's a sort of 3 to 6 year internship. Many of you might read about it in the paper. There's a lot of TV shows that illustrate it. My personal favorite is ER. Does anyone remember that? Because I gave a lecture recently. Someone said, "What's that show?" Heard of George Clooney? It's a very stressful time, but it's changing quite drastically. And I'm going to talk about some of the changes that I think will lead to our designs changing as well. I wanted to show you a clip of Dr. Carter. We all remember him. His first day.
John Carter.
Yes. It's just about a minute or so.
Let me understand, okay? I just hope you like it. Oh no, would you look at this? That's the first tailored white coat I've ever seen. What does it mean? Think he knows anything?
Knows how to dress.
Well, that's my student. I'll find out. John Carter.
Yes, sir.
Peter Benton. You the surgical student?
Yep, third year.
Good. We're going to be spending a lot of time together, so let me show you around so you'll be oriented. This is the admitting desk. If you need someone paged or a chart called up, you do it here. This is Timmy. Don't shake his hand, he's afraid of disease. This is the way to the lab. We do crits, counts, spin downs. Chemistries are marked with these slips and left at the front desk. Mark everything stacked, whether you want it fast or not. The chem lab is 7022, the heme lab is 6944. Come on. Everybody gets an IV the minute they walk through the door. Use an angiocath with a 16 needle. You need a large bore in case they're bleeding and you need to transfuse them. Do you know how to start an IV?
Actually, no.
I thought you were third year.
I am, but all I've done is dermatology and psychiatry.
The well-dressed specialties. Well, you find that surgeons actually try to help people, not just fill them. Now, the best way to do this is to pull the skin tight so the veins don't roll and go in low. Once you're in, pull the gizmo out and hook it up to here. This is Carol Hathaway, the head nurse. John Carter.
Hi.
She's terrific, isn't she? She goes with an orthopod that used to be a Big Ten tackle and looks like King Kong. Now, what you want to do is you want to take it, moderate flow, 2 or 3 drips per second. That's it. That's all there is to it. Okay?
Okay.
I think you can get a sense of the stress level that staff can encounter in the hospital just by looking at that clip. So that was sort of my segue into the staff space. And I'm very close to being a resident, so I can really understand what he went through. It is really much like that. And the set of ER actually deliberately made the sets to be very stressful in terms of the color choices and the noise. Kirk Hamilton is actually a consultant, and he'll tell you stories of going to the sets, giving some advice on how to do that. So where do you think we're spending our time? This was a study done by Hopkins and the University of Maryland, and they looked at interns and residents. And most of their time is with this, indirect patient care, which really means talking to other providers. Healthcare is complex. We need a team to care for every patient. It's no longer just one physician who can do everything for complicated patients with multiple disease processes. But we're also at the computer. So that's what that 64% is. Of course, we're at the bedside for 12% of the time. We're learning. And the 9% is, I think, sleeping, walking, and socializing. So we do a little of that. But here's the key chart. So 7.7 minutes a day per patient at the bedside, which is not very much. Compared to 10 years ago, if you look at 2003, we were much more at the bedside, and we were not at the computer as much, and we were not talking to the multidisciplinary team as much. So these are big, big changes. And the question is sort of to ask, where do these changes occur in terms of space? If we're talking about patient rooms and not being in there, when we are in there, we're actually doing procedures at the bedside. This is a typical shared room in New York. Yes, we have shared rooms still. I'm sure in Boston we probably have shared rooms too, but I know it's shifting, but we'll still continue to see them, I'm sure, for a lot longer. When we come in to do a procedure, in internal medicine, we like to drain fluid. We take it out of everywhere. Lungs, belly, joints, whatever. Stick needles in, get fluid out. I used to show a picture, but I took it away because one of the architects turned kind of pale one day. So no gross pictures. Where do you think our sterile field is? We all know this, right? You have your drinks and your juice boxes and your turkey sandwich, and then someone comes and says, clean it all off. I need a sterile field for my procedure. I always found it very awkward to use the patient's bedside table. Or we use the patient themselves. You just put a sterile drape over a human's body and say, don't move, and put all your syringes and everything there. It's not very safe to do that. Sometimes you have no choice. What about our sharps container? I remember doing a procedure here, sharps container over here. Very awkward. And of course, trash and biohazard are always important to think about. But we're going to the patient now. I mean, we probably all know this. Procedure rooms are really no longer. We have a few of them in certain subspecialties of cardiology where we need imaging to do certain procedures and put in certain lines, but mostly we can just go to the bedside and do almost anything. What about the hallways? So this is another message in terms of, let's think outside the box a little bit. Just as I was saying with the patient room, and maybe the bed is not the actual focus or shouldn't be the main focus. What about corridors? This is a hospital in Houston, Texas, a surgical ICU. Whoever said we're going to go paperless, we all use paper. Our white coats are stuffed with papers. So we always take these bedside tables out to try to write things down. But rounding happens in the hallways. In the ICU, we can round anywhere from 5 a.m. all the way to 2 or 3 p.m. every single day. Big activity happens in the hallways. We can't all fit into a patient room. So a lot of work is happening in the halls, a lot of communication. In front of a patient's room, we've got our PPE station, we've got a gown and glove, clean our stethoscopes, that's all happening right outside in that intermediate space. Nurses have their workstations on wheels, maybe they're charting. So that's talking about staff and visitors, but patients actually come out of their rooms if they can, if there's no infection and control issues. Where are they doing their physical therapy? It's in the hallways. They're going up and down. And Memorial Sloan Kettering in New York recently, they get people up who are intubated. They have a tube down their throat, they're on a ventilator, they get them up. Good data to show that then they don't develop ICU-acquired weakness and all other kinds of deconditioning. One patient, when he was extubated, said to the main doctor, I just don't know how far I go every day. I can't tell if I'm improving. So they installed certain numbers along the way. You go and visit and you'll see 5, 10, 15. It's made a huge difference to the patients. This was their running track, so to speak. This was how they gauged their progress. very dynamic space in the corridor. I like this topic. Daylight for staff. This is a racetrack. This is actually Memorial Sloan Kettering's ICU. It's a renovation project. It won an ICU Design Award in 2008. Dr. Neil Halpern runs the unit. And this is the staff core, kind of your typical racetrack model. Perimeter windows. I call this the no sun zone. That's where we work. But there are solutions to bring light in for staff. And I like to advocate for that. I think that's important. This is an ICU in Melbourne, Australia called the Alfred, a very nice unit if you can visit. The use of clear story windows brings a lot of light into this staff core. And in Australia, they have curtain bays for their critical care center. These patients don't stay very long. They're usually moved, but not single rooms with breakaway doors, and they don't have individual windows per patient. This clear story system really does have a nice effect, and staff really gain a lot of the light. This is the Paimio Sanatorium in Finland. I wrote a couple of articles about this too. This is a building that changed my whole career. I was a young architecture student traveling through Scandinavia, walked into this building and realized it's a hospital today, a general hospital. But it was the very first time I'd walked into a healthcare facility and didn't have that queasy antiseptic smell feeling. And it puzzled me for a while. It's an interesting building if you read about how he designed it. He really looked at tuberculosis and designed the hospital around the patient, but the disease specifically. So he knew that people have sputum that's coming out of their lungs, and you don't want to spit and wash your hands in the same place. So why not do a sink that's splash-free and a sputum basin right next to it? So a lot of different thinking and very interesting patient-centered model, but single-loaded corridors with a very nice yellow color that really brings in the natural light and makes it have a very uplifting feel. So burnout. This is a topic that I guess is close to my heart. I just finished residency. I'm still recovering from loss of sleep hours. We know and we have good evidence that burned out doctors aren't doing well. They're making mistakes, they're depressed, they might turn to substance abuse. A lot of publications in the media. Time magazine, The Epidemic of Disillusioned Doctors. This is a New York doctor who wrote this. Canada, Brian Goldman, he's an ER physician in Toronto. Canada's doctors, the best, the brightest, and the burned out. And if you think they're burning out in their 50s, they're not, it's their 20s. That's a big problem. They just released a big study. Penny and I were just talking about it today. We both happened to see it in JAMA, Journal of the American Medical Association, between 21% and up to 43 or 44% of residents are depressed and burnt out. I feel that their work conditions contribute to that, or can contribute to it. Because this is where we work. These are the trenches. So the first day of residency, you're gathered into a room and you're told your one goal is to survive. Whatever you need to do, you need to survive. This is like going to battle. Put on your uniform. That's your scrubs. Go into the trenches, which is the wards and the ICU and the emergency room. Put your head down, you do your work, and you never look back. It's not the most conducive space to learning and nurture and caregiving. This is our emergency room, and you can see they've actually divided each patient bay. So this is one. I remember I couldn't turn sideways and get between two gurneys. An example of a New York emergency room. This is where I think staff should be able to go. This is New York City. We're high up in Washington Heights. Look at the views. I took this from one of the pedestrian bridges on the campus one day when I was walking to clinic. But in reality, we don't go here. We can't stop here. It's not convenient in our daily flow. So you might be surprised, but this is where we do go. It's not uncommon in the ICU or closed units or even on the ward, because it's close, where you want a moment to shed a tear or think about a procedure that just went badly, went well, family member of a patient you have passed away. You come into these stacks of clean utility rooms and have your moment. Should it be this way? We'll do a little bit of a medical lesson here. There's just a video clip. I clipped together a few teaching videos of, these are mock patients and doctors, it's a teaching video, doing different exam maneuvers. And I want you to watch them and tell me what you think is similar between all of the different videos. I want you to look at the provider's positioning, essentially.
there are many different ways to listen to the belly, and many people will tell you different things. In the textbook, they say you should listen in all 4 quadrants for at least 30 seconds to hear bowel sounds. You can do that if you like. Realistically, most people just take a listen for about 10 to 15 seconds, somewhere in the center of the belly, and always pushing very, very gently. And the thing that interests me the most is whether bowel sounds are absent or present. Some people will tell you that very high-pitched tinkling bowel sounds might indicate a bowel obstruction. Fair enough, but realistically, present or absent are what we're most interested in.
Now we're going to demonstrate the examination of the vital signs, and we'll start first with the blood pressure. And one of the most important things to do first is to ensure that your blood pressure cuff is the right size. You want to place it on the arm, snugly, ensuring that the artery index marker is actually over the brachial artery and that it is about 1 inch above the antecubital fossa at the level of the heart. You want the blood pressure cuff on nice and snug. You want the patient's arm relaxed, and you want to first feel for where the brachial artery is and ensure
lastly, when you're auscultating someone's precordium, you usually use the diaphragm rather than the bell. The diaphragm is much better for high-pitched noises, and that's what we usually hear with things such as S1s and S2s. The bell is useful for hearing more lower-pitched sounds, and that can be used for listening for S3s and S4s. We will not discuss murmurs today.
Follow my finger. And do you see any double? And I don't observe any redness or swelling of the conjunctiva on observation of your eyes. Now,
So those were different exam maneuvers. Maybe some of you have seen me show this clip before, but you notice that the provider's always on a particular side of the patient. This is medical convention in all of North America. Our anatomy is not symmetrical. We have things like our liver is on the right. And we look at a particular vein in the neck when people are lying down to tell whether they're dehydrated or maybe they have too much fluid on board if they're in congestive heart failure. So examine from the patient's right-hand side. If you are in medical school and walk into an exam or a pretend exam with a mock patient and you approach on the left, you fail. This is my clinic room. Can I get to the right-hand side of my patient? Not easily. And then because we're talking about ambulatory care, the questions coming up with different clinicians is whether this exam table is really necessary anymore. The Affordable Care Act, we're pushing patients through. We've got 7 minutes per patient. In a general internal medicine clinic, do you really need to lie someone down? Certain exam maneuvers, like orthopedics, you do. Ear, nose, and throat, you need a specific type of chair, but maybe it could be more of a recliner type of device where the patient can sit, and they can shift position, and don't have to move. Then maybe your room can get even smaller, get in more rooms. Now for an elderly patient, there's a lot to be said for watching them go from a chair to an exam table. You can almost tell more about their functional status at home from that than from asking them questions. I touched on rounding before. I'm going to touch on communication again. I think it's very important. We know that it's one of the most frequently cited causes of preventable harm to patients. We need to communicate. And I thought I'd link it to lab design. So these are 2 laboratory buildings. This is one of my favorite places, the Salk Institute in California. Maybe some of you have been there in WeCon. This is up in Toronto, the Terence Donnelly Center on the U of T, University of Toronto campus. But look at here, you can see these gardens punched out. These are black olive trees, multiple height garden spaces amongst the labs. Both of these buildings have this in common. Louis Kahn brought people outside to these chalkboards, and every time I go, there's different formulas and things up there. It's always fascinating. I never know what it means. And then here's the Terence Donnelly Center, whiteboards inside. It's cold up there. But look at this, 80% of scientific breakthroughs don't happen at the lab bench. They happen in these areas. So can we take that out of the lab, per se, and into the clinical environment? What about the doctor's lounge? Sort of an old-fashioned idea, maybe. Do we still have that? This is a Canadian publication. I thought it was a good quote, but they basically are saying that the lounge is really non-existent, and they're questioning where is that new hub of activity amongst providers. I can tell you where it is at my hospital for residency. You might be surprised. Here. We don't take the elevators, but we have 12 patients to see. They're on 4 different floors of the hospital. Let's take the stairs. Take the stairs. Everyone else is taking the stairs. Not the patient's families, providers. And so it's these fantastic interactions where you bump into the pulmonologist you were going to page and talk to digitally later, and you can now talk to face-to-face. What if we had a different kind of staircase and not your fire egress stair? What if it was a nice grand staircase with landings and alcoves? Would encourage exercise also. Nighttime. The hospital really changes. I had a little clip, so I wrote a diary as well as my design notebook. Even just a few notes here and there. I thought I definitely need to remember how I feel during this residency, but I used to write about the night. And I said, the hospital is quiet at night, and there's an entire community of staff here that spend their lives at night. The eerie quiet of the halls, there's a sense that anything can happen at any minute, but you are all alone. There's a time in the dead of night when you can finally read and learn and think. There's less beeping at night, less chaos. I like it, except for the torture of trying to stay awake when my body begs for rest. But sitting down and closing my eyes, even for 15 minutes with no sleep, can refresh me for hours. The call room with double bunk beds, hospital sheets, and no computer or nightlight make it a difficult sleep if I even have time to go there. So this is a good slide. All right. So there's a big debate right now in the literature. Nobody knows the answer. You can think about it for yourself. Here's the doc. Here's your doc, and you are this black dot is you as a patient. Who would you rather have as your doctor? So here's option 1. You come in at time point 0. You're walking, you're talking, you're not feeling so good, and you meet the doc. He takes care of you, does some blood tests, imaging, but you really decline. Maybe you have a cardiac arrest, something goes awry, and you end up in the ICU. You're intubated, you can't talk anymore. But he's seen that progression. He's pretty tired. It's hour 34 of his shift. Okay. Option 2. This guy's really fresh, right? He's just got here 2 hours in, midnight, he just got here for his night shift. He heard about you from this guy, this doctor. For a few minutes, they had a 10-minute handoff. But he hasn't seen you as a walking and talking person. He just sees you in that bed. He hasn't seen that progression of illness. So which is better? And we simply don't know. We've changed our work hours from the old 36 to 48-hour model to the 16-hour model. That was because of New York at our hospital. There was a death of a young woman whose father was a very prominent figure in New York and questioned whether tired residents were the cause. And if you know the Swiss cheese model of errors, a lot of slices of Swiss cheese have to line up with one hole that goes right across for an error to happen. It's usually not just one slice of cheese that causes something disastrous. But the point of this slide, we don't know, and I don't think that we'll ever revert back to this model, but there are big problems emerging with this model. And the problem is the handoff. Nurses have a good template for this. They've handed off for years. 12-hour shift, 12-hour shift. They have a template of what they need to exchange in terms of information. We don't. We sit in the nursing station, we find a place in the hall, in the fire station, we try to exchange information quickly. We don't have a place for handoffs, medical handoffs right now. It's an example of a call room. Can anyone tell me how to get to the top bunk? Because I never figured it out.
Climb up those little things at the back and throw yourself over.
I didn't have to jump down in a moment's notice. So with these new work hour regulations, I sort of postulated we'll see the end of call rooms, at least call rooms like this. Our hospital administrators came down one day to look at them and said, we're going to take this room, we need it, it can be an office. Besides, you guys shouldn't need to sleep. You're only working 16 hours, you're not supposed to sleep in a 16-hour shift. But you heard that diary entry, you still got to rest. So this is your traditional on-call room. I would like to kind of postulate that we do something like this. Smaller alcoves, we don't need full rooms, recliner chairs, iPod plug-ins. Take a few minutes, rest. You can really rejuvenate for hours after. And so I really do believe that we can break some of these barriers, this metaphor of the hospital as a battleground with design, and make the building part of this operational solution. And so some design trends going forward, I alluded to them already, but just to summarize, this shift work and handoff model we'll start to read more about and the research will come out, but we will need spaces for the handoff of information because shifts will not get longer. They will probably stay the same or even get shorter. night float is now a reality. Instead of working 48 hours, you got a doctor who works night after night after night after night. So they may not need to sleep for 5 hours, but they need a rest area. And we're not at the bedside. So where are we? We're in the conference rooms, we're webcamming patients in. So this conference room time to collaborate is now taking over. And this is sort of my own thought. The MD, that medical doctor lounge, is really obsolete now. We're looking at the MD, or the multidisciplinary collaborative lounge or space. And I like this. This is what Kirk had told me at one point in time. He said to him, these are all just little tidbits. I don't know how they can matter. And he said, that's okay. They're little anecdotes, but they can lead to confirmation studies, and you can really create change even through an observation. So that was all I had to say. I'll give the floor over to Penny, but hopefully you found it interesting, and I'm happy to open it to questions, or if anyone wants to email me with any thoughts or tidbits that go along with anything we talked about. Thank you very much for coming.
To learn more, visit www.humancentereddesign.org/news-events/institute-lectures-next-lecture.